It's my pleasure and honor to introduce Dr. Seilesh Babu from the Michigan Ear Institute, where he's currently the president. And thank you for coming to speak to us today virtually. And he's going to be talking to us about conductive hearing loss. So,
yeah, thank you very much for the introduction and the invitation to give the talk. The topic that we decided we were going to talk about is the evaluation of conductive hearing loss. I don't have any relevant financial disclosures associated with the talk. And what we're trying to accomplish is we would like to create a differential diagnosis for conductive hearing loss, determine when appropriate testing and imaging is indicated, and determine when surgical intervention is warranted. I'll briefly cover the middle ear mechanics so that we can talk about it, but just a really high overview of the mechanics of the middle ear. As we know, sound is going from an air medium to fluid in the cochlea, and this causes an impedance mismatch. And that impedance mismatch causes a loss of energy of approximately 30 to 35 decibels from the air to the fluid medium. And luckily, we have the tympanic membrane and the ossicular chain to help overcome this. And this couples together the air and the fluid to try to reduce this mismatch as much as possible and create a transformer of the energy. And the most important of this is the diameter or a surface area of the tympanic membrane to the area of the plate. And it's approximately a 17 to 21 to 1 ratio of the final vibratory area of the tympanic membrane to the footplate. And then we have the ossicles themselves, of course, that work as mechanical levers to transmit the sound, and the length of the malleus to the location of the incus provides a gain also, as well as the orientation of the ossicles and the way they slip and they can rotate on their axis. So we should get a theoretical gain of that sound energy to normal, but we don't seem to get that. The actual gain seems to be approximately 20 to 25 decibels, and there's still a little loss of energy. And why do we think that we lose some of that energy? That it may have to do with different portions of the tympanic membrane are vibrating at different frequencies, and that has some impact on the ability of the sound energy to transmit to the footplate. There's slight slippage that occurs at the ossicular chain around the axis of how they rotate. And there are certain either stiffness or masses of the tympanic membrane, whether it's tympanosclerosis, scarring, previous infections, that may reduce the theoretical gain again. And then the reduction of the middle ear volume from potential eustachian tube issues. And maybe, as we all know, when patients say, I can auto-insufflate, my hearing's better, even without surgery, things like that, that could imply that there's the impedance mismatching that they're able to then accomplish just by auto-insufflation. And of course, we know ossicular discontinuity can result in a change in that sound energy. And if you have complete disruption, as the picture on the left here, you can end up with a maximal conductive loss of 50 to 60 decibels, especially if the tympanic membrane is intact. And then you can get a variation of that type of air bone gap if you have an incomplete discontinuity, where maybe you get a fibrous connection or some scar tissue that can still give you some transmission of sound, but just not perfect. So the talk today is going to be on the conductive hearing loss, which of course implies the disruption of sound from the external ear to the cochlea. And numerous things can cause this problem, from external ear problems, middle ear problems, and inner ear problems. So we'll go through those with this talk. There are different patterns we can see on audiograms that may give us some insight as to what the problem is. On the top left, there's a low frequency conductive hearing loss. On the top right is a maximal conductive hearing loss with a decrease at 2000 hertz in the air bone gap. And in the bottom left is a mixed hearing loss, similar to the one on the right. So these different patterns don't always tell us exactly what's going on in the middle ear, but you have some idea that this upper left may represent possible fluid in the middle ear, possible eustachian tube dysfunction, possible superior canal dehiscence, versus a maximal conductive loss such as this would imply some kind of ossicular chain abnormality, potential otosclerosis if there is the true CARHART notch, which we'll talk about. Versus mixed hearing loss, which could represent cochlear otosclerosis or other abnormalities of the inner ear in combination with middle ear issues. These patients obviously come in and say, I have a hearing loss. They can have unilateral symptoms, which is probably more common than bilateral in conductive hearing loss patients. It's important to do a thorough otoscopic evaluation of the ear with pneumo-otoscopy to see if you can see the movement of the eardrum. Is there Malleus head fixation, which is a real challenge to pick up on in the office, but it can be. Obviously, you're looking for whether there's fluid, is there good dynamic movement of the tympanic membrane. It's critical I tell the fellows here that I think it's critical to do a tuning fork examination on every patient, because then you get used to what does the audiogram match up to what you expect it should be. And in conductive hearing loss, it's critically important to do tuning fork examination on the patients. And then we check an audiogram, and in combination of that, we can do a tympanogram, which I don't necessarily find that useful in the evaluation of patients with a conductive hearing loss, but obviously if you're looking for fluid or decreased mobility of the tympanic membrane, it's helpful. I do think acoustic reflexes is a critical component of testing. So in all of our patients, if they have a conductive hearing loss, they automatically, audiology already knows to automatically get acoustic reflexes in those patients, especially if they're a new patient coming in for that evaluation. And then imaging can be part of the workup as well. And many times these patients will already have had a CT, or we will recommend getting a CT to further evaluate their conductive hearing loss. If we start from the outside in and we just look at generic causes of conductive hearing loss, look at external ear canal lesions, osteomas, exostoses, masses of the ear canal, polyps, sclerotitis externa. Anything that, of course, blocks the transmission of sound from the ear canal can cause a conductive hearing loss. The things that I see sometimes that require some surgical intervention are exostoses, such as the picture on the right, where you have multiple sites of closing of the ear canal, especially in Lake Michigan here. We get cold water exposure, and that definitely causes a fair number of patients to have this. I know in certain parts of California, you have a lot of surfers that actually have similar findings. And just the other day, actually, we did this case here with a large osteoma in a 19-year-old that was blocking the ear canal completely with wax and debris, and potential early cholesteatoma from behind it, also with a mild conductive loss causing the issue. So we did a bony canalplasty and we're able to chisel this out and remove it. And then I tend to drill the bone a little bit. Maybe it'll reduce the chance of recurrence, which I've not really seen, and then closing it up. So usually this is a surgical procedure that's relatively easy, straightforward. If you're going to do a canalplasty and exostoses where you could have multiple areas of this, you always have to be careful of your drilling, that you want to know where the facial nerve is the whole time, because a potential risk of this type of surgery is a facial nerve injury or restenosis. If we move on to the middle ear, and the most common probably causes of conductive hearing loss will occur in this region, which would be a tympanic membrane perforation, middle ear effusion, ossicular chain issues, pathology in the middle ear, such as cholesteatoma or other masses. So if you focus on tympanic membrane perforations as a part of conductive hearing loss, the sound conduction is obviously altered because we're losing that ratio of functional tympanic membrane to the footplate. Interestingly, the amount of conductive hearing loss can vary based on size and location. So we've all seen patients who've had even a significant perforation of the eardrum, and they can have normal conduction of sound. And then we have patients who have a very small tympanic membrane perforation, and for some reason that can cause a conductive hearing loss. I will say, if you have a small perforation and a significant conductive hearing loss, 25, 30, 35 decibels, I would actually say, well, then be prepared in the surgery that there may be an ossicular chain issue as well, and that you want to make sure you always palpate the ossicles, which is a common theme that you'll hear in this talk. The treatment for it, which is a talk in and of itself, depends on numerous factors, whether or not you should fix a tympanic membrane perforation, especially in a child. You want to consider, is this unilateral or bilateral? What's the amount of the conductive hearing loss? What size and location of the perforation? Is there water sensitivity? What's the contralateral ear status? Should we wait until the eustachian tube maybe is more functional? Should we wait until drainage has stopped? Is the drainage coming because of the perforation? So there's several factors that go into whether or not a perforated eardrum should be repaired, especially in children. If it's unilateral, I'll tell them to wait till they're a little bit older. If it's an adult patient, of course, we probably recommend repairing it relatively quickly. Clearly, sometimes you have to repair a tympanic membrane perforation in a child, and then they eventually sometimes need tubes back in that ear again, and that's a complicated discussion with the family, but it's an important one to have because that can happen. And the approaches on how you fix a tympanic membrane perforation can vary from the location, surgeon comfort, surgeon preference, from a medial tympanoplasty, a lateral graft versus an over-under approach. The important thing is that you check the ossicular chain every time you're in the middle ear and be prepared with appropriate prostheses if need be to reconstruct the ossicular chain at the same time. Middle ear effusion, probably the most common cause of conductive hearing loss that develops fluid in the middle ear space, reduces movement of the tympanic membrane on pneumo-otoscopy. The tympanograms will be either flat or potentially negative. The audiogram does show some mild version of conductive hearing loss. Typically, we would want to hopefully observe the patient, let it resolve, but I think if there's a significant conductive hearing loss, putting tubes in the ears is indicated in that scenario. And then as they get older, the idea of a dilation of eustachian may be possible. The FDA has approved dilation greater than the age of 18 now, but there's definitely numerous studies that are coming out looking at dilation at younger ages, maybe to reduce the need of more tubes in the ear. And then ossicular discontinuity, which is probably a very common thing that we'll see, results in conductive hearing loss, and this is magnified if the tympanic membrane is intact. This may be due to the sound cancellation that occurs as vibratory sounds are hitting the round window and the footplate at the same time, so you get some cancellation effect, which then results in a larger conductive component. Typically, I see this related to chronic otitis media and cholesteatoma. You can see it in the face of trauma. I have a couple cases just to sort of highlight different episodes of conductive hearing loss. So I had a gentleman who was 56 years old who had a left-sided hearing loss for decades. He said he just didn't want to do anything about it. He was fine about it and that he was fine as a child and in high school. But then as years went on, he just kind of noticed a hearing loss on that side. No other relevant history. His contralateral ear was normal. His physical exam showed that he had a normal exam, normal mobility of the tympanic membrane. His Weber lateralized to the left and his Rene is abnormal on the left, consistent with a conductive hearing loss in that left ear. So we obtain an audiogram, and his audiogram shows a high frequency loss in his right ear and a pretty significant conductive loss on his left ear. And so we think about what are the things we should consider, and the options would be, should we just recommend a hearing aid or a bone conduction device? On a side note, bone conduction devices is definitely something that we should not discount. They can be a very good option for patients, whether you're going to put a percutaneous or a transcutaneous or an active implant. The technology is getting better and better for these type of treatments. I'm not talking about in the talk here, but that's a separate aside. In this patient, should we obtain acoustic reflexes, which again, we tend to do in patients with a conductive hearing loss. I have several referring doctors, and they typically seem to get an MRI scan, and I would say it's not indicated to get a MRI scan in this type of quote unquote asymmetric hearing loss in a conductive component, but I do see practices that seem to do it, and I would encourage them that it's really indicated to do that as opposed to a CT scan, which may be more beneficial. And then we offer middle ear exploration, and in my mind, this is a good candidate to offer a middle ear exploration, which we did. So acoustic reflexes were absent. A CT scan of the temporal bone did not reveal any abnormalities, such as enlarged vestibular aqueduct or superior canal dehiscence. So we look at this and we try to wonder, well, could this be otosclerosis, which is a little unusual configuration? Could it be fixation of the ossicles? Could it be ossicular discontinuity? My feeling is it's probably ossicular discontinuity, given that maximal conductive hearing loss. And let's opt for a middle ear exploration. So we explored the ear, lifted up the tympanomedial flap. This is the left ear, and here's the incus that you can see here. You can see the footplate off in the distance. And what's interesting, once we elevated the flap and we took a look, we could see the malleus and incus moved well, and the stapes footplate moved well, but there was no superstructure. There was no stapes at all, which is a little unusual in this case without a history of trauma or other scenarios. So it was couple options as to how do you fix this and what do you do with a mobile footplate and try to reconstruct the ossicular chain. Options, of course, could be take out the incus and put in a total prosthesis to the footplate, maybe do a stapedotomy, which I would really do in a mobile footplate, but a consideration, and then put a piston in. In my case, actually, I decided that I'm just going to leave the anatomy alone, and I'll put a total prosthesis and try to bridge the gap right to the tympanic membrane with a cartilage cap in case I ever needed to go back in, I would leave the incus and I could use it for further reconstruction if this technique didn't work. And of course, we showed the good ones where it actually did work and it closed the air bone gap significantly, except for that high frequency, which he's more than pleased with. So there are numerous ways to reconstruct the ossicular chain. Again, probably a talk in and of itself, whether you do an incus in position, whether you, artificial partials or total prostheses. There are some cases where I use bone cement. I'll show you a picture of. I think there's going to be some future in some 3D printing where we're able to use imaging and develop the actual prosthesis for the patient to be using in situ, either by planning or planning for it in the future. That could be something that comes up. So I think when you have an ossicular discontinuity and you're going to explore the ear, I think it's very appropriate. You have to be ready for unusual findings. You have to look for any traumatic issues that may have caused some unusual ossicular connection issues. There can be congenital issues that you have to look for. There have been several times where I've done surgeries and either I'm doing a second revision surgery or even my own. And at the time of surgery, initially, I thought things looked great. And I don't know why there's still a continued conductive hearing loss. And then I have found that sometimes the stapes crura, they seem to be intact and you push on the incus and it seems to move. But then if you take a right angle and you actually sweep it right between the crura and the footplate, you actually see they're not in contact actually. And that's what's contributing to their conductive hearing loss. And I've seen that twice now. And so then you take out the suture and put in a prosthesis. Here's an illustration of a case of a right ear where the malleus here, incus is here and stapes is here. And there's a little bit of a connection between the two. And that space between the incus and the stapes is pretty close. And the patient had a significant conductive hearing loss. And I opted in this case to use bone cement and carefully place the bone cement on the incus to the footplate and got a really good result with that. But you have to be careful you don't get this on the footplate. You have to be careful it solidifies without dripping anywhere. And I don't use it a lot, but it does work in certain indications when it's like that. Here's another case with the left ear. So malleus is up here and the incus actually ranges way up here. And there's just a fibrous connection going all the way down to the stapes. And again, with a pretty significant conductive hearing loss. So in this case, I wouldn't use bone cement. It's too far of a gap. I would take out this little remnant and then put in a prosthesis. So we took out that little remnant of stuff and then put in a partial prosthesis here to reconstruct the ossicular chain. The second case, just to illustrate some other topics of middle ear pathology, is a 21-year-old male who had presented with a chronic history of ear infections. A child had several tubes in the ear and now comes in with a conductive hearing loss in the left ear. And this is the exam of the ear where you see a whitish mass. Could represent congenital cholesteatoma, but when you can palpate on it, it seems firm, more consistent with the Tympanosclerosis, with a pretty significant conductive hearing loss. So we obtained acoustic reflexes, which were absent, consistent with some type of abnormality of the middle ear potentially. Imaging could be obtained in this scenario versus surgical exploration. I don't think I got any imaging. I opted for surgical exploration. And on surgical exploration, when we palpate the ossicles, if the video is playing, hopefully you can see, you can palpate the incus and the stapes and they both move fantastic. And then when you go to push on the malleus, I cannot get the malleus to move at all. It moves just very slightly, but the head of the malleus is completely fixed. And so the question is, what do you do in that scenario? There's probably several different ways to fix that problem, but I opted to remove the incus and then resect the head of the malleus. And that malleus head, you could see the top of the head was actually adherent to the tegmen. And so you always have to be slightly careful when you're taking these out that sometimes you get a erosion or a trauma to the tegmen, potentially to the dura. So just want to be careful you're in this, that you want to take it out gingerly. And of course, he got a good result with the resection of that malleus head fixation. Tympanosclerosis is seen very commonly, and I think it's worth at least discussing. In the etiology, it may not be understood. There is some correlation in some article of H. pylori infections potentially causing that. Maybe related to previous infections. It seems to cause a hyaline degeneration and then calcification of the lamina propria. And these plaques typically can just be found on the tympanic membrane and usually don't cause any issues or problems, except when we're we're pairing a tympanic membrane perforation. We have to have this long discussion in the OR about whether or not we should resect this tympanosclerosis in order to fix the TM perforation, or can we just leave it alone? And I think in my practice, I've kind of gone both ways. Sometimes I'll take it out. If it's not impacting the ossicular chain, I tend to just leave it and then just reconstruct around the tympanic membrane around. But there are some times where the plaque is so big that I have to remove it. And then really when it becomes a problem is when it starts surrounding the malleus or the ossicular chain, and you have to figure out how you're going to work around that sclerotic plaques around the ossicular chain. CT scan and intraoperative palpation can help in making that diagnosis. And again, like I said, many times you can just leave it alone. There is a slight association when you have tympanosclerosis that you can get this Malleus Ankylosis. Sometimes you can see it on imaging. Sometimes it can be congenital. It can be from chronic infections potentially that causes a fibrotic changes and osteoblastic formation that causes this Malleus fixation. And it can be a cause of failed stapes surgery if you're not paying attention and don't palpate your ossicles well. That could be one of the reasons why stapes surgery didn't work the way we wanted it to work. And as a transition then to talk about otosclerosis, again, a rare entity in and of itself, but a common cause of conductive hearing loss that we'll see in our practices. It has to be well known to the general otolaryngologist, especially that probably the most common cause of conductive hearing loss isn't otosclerosis, but yet that seems to be a common thing that will be sent to us to look for it. And they don't have all the typical findings, and in fact, sometimes repeat the audiogram because the conductive hearing loss does not match up with what we're looking for. But otosclerosis has several phases. It has an otospongiosis phase that is the early sign, and that's where you can see the vascular changes that occur on the promontory. And you can see that Schwartz's sign if you look in the ear, and it can be very distinct. And then it goes through a transitional phase, and then you start getting the late phase of the sclerotic plaques that develop around the footplate. It is autosomal dominant, and genes have been found to contribute to this issue. It seems to be a higher incidence of Caucasians and in females. Pregnancy and hormonal factors may play a role in that. And typically, this is a age of usually in the mid 30s to 40s when you see the signs of otosclerosis. You obviously can have congenital or juvenile fixation of the stapes at a younger age, which may be causing their conductive hearing loss as well. The most common site for this is at the fistula antefenestrum, where you get fixation of the stapes from the otosclerotic plaque. You can get a mixed hearing loss associated with it, and it theoretically could be from toxic metabolites that are entering in the inner ear. It could be direct extension of the plaques maybe into the inner ear. It can be vascular compromise from narrowing of the vascular channels and maybe contributing to why there's a nerve conduction that occurs. Fluoride treatments has been used in the past to maybe prevent some of this from occurring. We ask patients, especially who live in Upper Michigan, would you have well water or city water? And if they have well water, we recommend them drinking bottled water. If in the face of otosclerosis, it may be preventing future damage or hearing loss. I had a patient who came in one time actually who said, hey, I have eustachian problems and I have trouble flying. And she actually came in just for tubes in her ears. And when you look in her ears, you saw these bilateral, severe reddish appearance of the promontory. And we do a tuning fork, it's normal. I got an audiogram on her and it shows this interesting, hearing loss that she has. And she actually said she didn't even notice any hearing problems. And so I obtained CT scans, and it shows this classic ring sign of the cochlea for a cochlear otosclerosis. It was sort of incidentally found she just wants tubes in her ears, and she's not bothered by the hearing loss actually at all. It was just an interesting pickup when we looked in the ears. The conductive hearing loss, like we mentioned before, can guide you and show you as to which is the more likely pattern of what you're going to find. So complete ossicular fixation or discontinuity will look like the audiogram on the left, where you see a big air bone gap. And on the right, you see this CARHART'S notch, which is a decrease at 2000 hertz. And the bone conduction seems to go down at that point. It seems to be artificially reduced because after surgery, when you close the air bone gap, you get closure of that air bone gap, and the threshold goes back up to normal again. So the explanation is unclear as to why you get a CARHART notch. Does it have to do with the anterior location of where maybe the otosclerotic plaque is occurring and the vibration different there? But it does reverse again, as I mentioned. And acoustic reflexes are important, especially in this day and age of superior canal dehiscence. Acoustic reflexes are designed as a reflex so that when loud noise comes in the ear, the ossicular chain stiffens, and we can measure that stiffening that occurs by putting noise into the ear, sound into the ear, and then measuring the tympanic membrane movement with a tympanogram. And it's a on-off response. You put the noise in, you get this reflex, and it decays a little bit, and then it stops, and you can measure that. And so if you have a fixed ossicular chain or you have conductive hearing loss, you actually shouldn't be able to stimulate the sound so much that you should get an absent reflex then in most scenarios with a conductive hearing loss. And so if you had a patient who had a conductive hearing loss and had intact acoustic reflexes, you'd wonder, well, that's weird. Is there something else going on in the inner ear? Is there something in the superior canal that needs further evaluations? And the other question that comes up is whether or not you should obtain CT scans in patients with otosclerosis. I think it does show some signs of radiolucence in the early diagnosis. You can then see sclerosis that occurs, and it can be diagnostic, but more commonly, it'll be normal. And so the debate would be, are you getting the CT scan to rule out other problems? And probably that's the reason why we would do it, is to rule out superior canal dehiscence. I typically do not get CT scans myself. I base it on the conductive hearing loss, the tuning fork, the audiogram, and acoustic reflexes. And if those all point to otosclerosis, I do not get an image. If there's anything unusual, such as dizziness, sound-induced symptoms, acoustic reflexes that are now normal, then I would get CT scan and further imaging. There's a question, I guess, if you did a stapes surgery and the CT scan came back normal and you have a report that it's normal and you end up with a dead ear, is that a problem? Is that a medical legal issue that you could say, well, doctor, why do you have a normal CT scan and you still perform surgery and now you got a dead ear? I don't think it's a reason not to get it. It makes me ponder the question as to, we take enough risk and issues when we do stapes surgery. We're trying to do everything that's appropriate for that patient, but it still can be spun around on us sometimes at times like that. If you're going to do surgery for the middle ear exploration, as I tell the residents and fellows here locally, make sure you have all the appropriate equipment, pistons, partials, prostheses ready to go at the start of the surgery. You don't want to have an open vestibule and then ask for a 4.25 piston, and then now they're running out of the room to go find it. And so it's very important that you have the laser ready to go. They've checked it, they fired it. They have the 1 or 2 different pistons that you may use, as well as a partial, and they have it in the room sort of ready to go. So it's just an important thing to make sure you take care of. And then as soon as you get in the ear, you always want to palpate all the ossicles completely, confirm that the stapes seems to be fixed, and then you proceed on appropriately. So, and then we'll switch gears here and talk about superior canal dehiscence, or third window pathology, is another cause of conductive hearing loss. Third window symptoms is caused by sound-induced or pressure-induced vertigo and imbalanced dizziness. It can be vague. They can have a low-frequency conductive hearing loss. They can have autophony, oral pressure, hyperacusis, especially to bone sounds like hearing their heels click on the ground, or sometimes hearing their joints move, hearing their eyes move, things that cause a little bit more bone conduction sensitivity. They can hear that. They can get pulsatile tinnitus. This can mimic a lot of different issues. Why we care in conductive hearing loss specifically, because they can mimic a conductive hearing loss, and you don't want to go operating on the middle ear if the superior canal or a third window is potentially the phenomenon. The pathophysiology, I won't claim to be an expert on how do I think the third window occurs. I do know that since we have this impedance mismatch that occurs, there is an impedance issue that occurs, that now the third window allows pressure and the sound energy to be released in a different way, and the basilar membrane isn't getting the full amount of pressure movement that it should. So the air conduction can be reduced, and the bone conduction is more affected, especially at the low frequencies at the apical turn. So that's why we seem to get a low frequency conductive hearing loss and a hypersensitivity to the bone conduction that occurs. I will honestly say I'm not sure I quite understand why it do what it does, but it does seem to be very consistent with patients clinically that's what they complain of. If you put a tuning fork on their elbow, for example, they'll say, oh yeah, I can hear that. If you put it on their medial malleolus, they'll say they can hear it. They'll talk about their eyes moving. So definitely there's some bone conduction that occurs. They classically will have this low frequency conductive hearing loss with supernormal bone conduction thresholds. Acoustic reflexes will be intact. And then you can get VEMP testing, and you can see a low threshold with the C-VEMP and amplitude changes on the O-VEMP. Again, more consistent with superior canal dehiscence. The goal of the talk is not to specifically talk about that, but now what do we do when we have patients that have superior canal dehiscence and otosclerosis? And a couple of things we have to think about is that just because you have a CT scan that shows superior canal with no symptoms, you have to separate these patients potentially and realize that there is an incidence of x-rays that are going to show superior canal with no clinical relevance. And now we're tasked with to separate those patients, and a patient who has potential otosclerosis, how are you going to decide what to do with them? So there has been data on this, and they've shown that patients with otosclerosis versus superior canal dehiscence versus both, that there's certain characteristics that you can look for. And of course, sound-induced or pressure-induced vertigo should not occur in otosclerosis. They don't seem to have hyperacusis associated with it. They will show a classic conductive hearing loss with a CARHART'S notch. CT scan won't show any abnormalities of the inner ear, and potentially you'll see some changes around the footplate. And if you do get VEMPs, they relatively are normal, except for they're absent because you can't get enough sound signal through there because of the conductive hearing loss. But typically you wouldn't get VEMPs in classic otosclerosis. And then superior canal dehiscence presents with the symptoms that we talked about. You would have acoustic reflexes that were intact, and a CT scan that now shows the dehiscence, and you can follow that through with VEMPs. When they're in classic categories between the two of them, it's easy to figure out what do. You clearly don't operate on one or the other if you find the offending problem. The problem arises when sometimes patients will have both, and typically they'll have otosclerosis and then a incidental finding of superior canal dehiscence. If they have classic symptoms of superior canal dehiscence as well as otosclerosis, then I think that's a challenge and probably would not recommend surgery necessarily for the otosclerosis. And there's some questions that we think about then in this scenario when you have both complicating matters. One is, can we achieve significant hearing improvement with surgery for one or the other? And is there an increased risk for sensory hearing loss following stapedotomy if you have a third window? Will the third window symptoms that may not be present become unmasked if you now perform a surgery and potentially create another window into the inner ear when you do your stapedotomy? And then which one should you address first, the otosclerosis or the superior canal dehiscence? And I don't claim to know the answers to this. There's been articles that have come out of even at the House Ear Clinic where they looked at concomitant superior canal dehiscence and otosclerosis and found that the results of hearing improvement is not as good when you have superior canal dehiscence. They didn't unmask any new patients with symptoms, but I think one patient continued to have symptoms despite the stapes surgery. So there's something to think about. That can you get closure? It's something that you have to pay attention to in these patients. Another study looked at 8 patients who had concomitant superior canal dehiscence and otosclerosis. 7 of them underwent surgery, and the most common result actually was a persistent conductive hearing loss and not significant improvement in the hearing if they had superior canal dehiscence at the same time. And in 4 of their patients, half of them actually unmasked some symptoms of superior canal dehiscence, such as autophony and hyperacusis and some imbalance. So there's definitely things that we need to take into account. We looked at our data, and we had patients who had incidental finding of superior canal dehiscence. So we looked at all the imaging that they had done, and interestingly, they actually didn't have any clinical symptoms of superior canal dehiscence. They just had radiographic findings, and we had 20 patients that had undergone surgery and incidentally had found that, and we found that they had very good closure of their bone gap and had no active symptoms or unmasking of superior canal dehiscence in that scenario. So just a follow-up to the superior canal dehiscence. So I think you should be careful in that scenario, and most likely observation is a good solution. And then whether you address the superior canal first versus otosclerosis first is a topic that's up to debate. And I don't know if I can answer that question that easily here. And then lastly, we'll talk about just some unusual considerations that we sometimes see when we do surgeries, that you can lift up a flap expecting to find a fixed stapes for otosclerosis. And when you do enough surgeries, you end up finding patients where you now have a dehiscent or a aberrant nerve that can be in weird locations. Sometimes you can move it out of the way and proceed, but usually you abort the surgery and then realize that the reason why they're having this conductive hearing loss is either the footplate is fixed or actually the dehiscent facial nerve is in contact with the footplate, causing the issue. So obviously a hearing aid or a Baha implant is a better choice for that. I have had prolapsed facial nerves. I've continued on with the stapes surgery. I did the stapes procedure. And I think once or twice I've ended up with a delayed facial weakness, which did recover, but it does make you think, is that really the right choice, or should we have just aborted at the time? The facial nerve does get better with time, but it just makes you on pins and needles when it happens. You also can find persistent stipular arteries. Again, the correct abort answer is you abort the surgery if you find this. I think if it's small enough, some of us will, since we already have a laser in our hand, we'll continue with the surgery and lyse it and keep going. But that's experience. I would tell you to do it probably in new hands or inexperienced hands. Probably the right answer is, again, abort the procedure. We've done cases where there's a dehiscent jugular bulb contacting the stapes even, or even up against the tympanic membrane, causing decreased vibration. Sometimes we can try to decompress this. I think many times you cannot decompress it as well as you'd like. And if they don't have pulsatile tinnitus and the only complaint is conductive hearing loss, probably leaving it alone is the right answer. But we can do some complicated surgeries to put the jugular bulb back in position, use some cartilage and some bone cement to seal it. I had a 9-year-old who had a right conductive hearing loss and pulsatile tinnitus. Actually, the reason why I got called is the otolaryngologist was putting in tubes for the second time. And when they put a tube in the second time, there was a fair amount of brisk bleeding occurring just from the incision. And so he called me from the operating room and said, I'm not sure where this is bleeding from. I think there's a glomus. Can I send him over once I get this under control? And I said, sure. It's weird that a 9-year-old would have a glomus tumor, but I'm happy to see what I can help and see. And so I did see the kid then in the office, and they had the bleeding stopped. They actually got the tube in. And when you look at the ear, you can see there's this reddish middle ear mass, which actually I thought maybe it was a glomus also, but I just haven't seen it in a 9-year-old. So we, of course, get a CT scan. There's audio, shows a conductive hearing loss on that side as well. So we get an audio, and the audio shows actually the carotid artery on both sides, actually, but more significantly on the right side has a aberrant carotid artery that is actually going right through the middle ear. He ended up getting an angio, and I think he's being followed by radiology for whether this needs to be stented or anything. I think we just leave it alone for the longest period of time, but there is a risk for aneurysm apparently that needs to be monitored. So the point being is that, yeah, be careful when you're looking at these things, because unusual things can happen. So in conclusion, various types of middle ear pathology can cause conductive hearing loss, and probably is the most common cause of presentation with a conductive hearing loss. And middle ear exploration is a good option for many of these patients that gives you the final answer as to what is causing the problem, and be prepared to treat the cause when you see it. But do an appropriate workup, whether it's audiogram, tympanograms, acoustic reflex testing, imaging, to determine prior to going in, can you predict what you're going to find, and can you optimize the success then? And then be prepared for unusual anatomy or unusual situations that you need to treat. So I think that's all the slides I have, and I appreciate your time.
Hello, my name is Dr. Kevin Peng, neurotologist here at the House Institute. Thank you for watching this video. The House Institute provides free educational videos for hearing health professionals worldwide. To help support videos like these and other educational efforts, please consider donating by clicking the link in the description box below. Your generous support allows us to keep videos like these at no cost for you and others. Thank you.